So what is emphysema? Emphysema is part of COPD. Part consists of changes in the airways, particularly the very small airways, that result in the narrowing of the airways, making it harder to breathe because of the increased resistance to flow due to the obstruction to flow in the lumen of these airways. But emphysema is a destructive process involving the walls of the air spaces deep within the recesses of the lung. And this destruction is due to the recruitment of inflammatory cells from components in tobacco smoke that then release, these are so-called neutrophils, that release enzymes called elastases that destroy the elastic framework of the lung, producing holes in the lung. You can see it with the naked eye on whole sections of the lung that are fixed in formalin after the lung's inflated. And then here we see it microscopically, these large holes, and that results in an interference with gas transfer, and it has some mechanical effects as well, such as the loss of lung elasticity so that the airways are not well supported and tend to collapse. So here we see COPD in a schematic form. It consists of a combination of these small airways changes with thickening of the walls of the airways and increased mucus production, narrowing the lumen, making it harder to breathe, as if you're breathing through a straw, a narrow bore straw, and then the loss of lung tissue, producing holes in the lung with poor support of these airways that tend to collapse. So that's COPD. Now, the tests that are used to diagnose it, the primary test is spirometry. And we measure a smoke equivalent forced expired volume in 1 second, FEV1, and its ratio. That's the primary test that's used to diagnose COPD. But there are other tests that are more sensitive to the presence of early changes in the small airways that may or may not progress to COPD, but they always are present earlier on in the evolution of the disease. The diffusing capacity for carbon monoxide is a measure of the integrity of the alveolar walls that are destroyed in emphysema, and it's a very sensitive but nonspecific indicator of emphysema. And we'll skip over airway resistance in a moment. We may discuss that later. But all the tests that we found, we performed this battery of tests multiple times in our sample, all were within not only within normal limits, but indistinguishable from the results in the healthy individuals, except for the airway resistance, which is a measure of resistance in the large airways, not the target of COPD. And the likelihood is that the edema that we saw, the swelling that we saw, is responsible for narrowing these larger airways and slightly increasing the resistance to airflow, not associated with, which should not be associated with any symptoms. So that's our study. Well, what about other studies? Well, around the same time, this Tucson epidemiologic study was being carried out, and the results reported in the same year we reported our results. And they had they used a better sampling method. They used a random sample, looked at a random sample of the Tucson population. These are the numbers, smaller numbers than we studied of marijuana smokers, and also they smoked less marijuana. They found no difference in the FEV1 between the marijuana in the marijuana group compared to the non-smokers. They did see some changes, however, in the ratio of FE1 to FVC, and in other more sensitive tests of small airways disease, it may or may not progress to significant airflow obstruction. And on the basis of those findings, they concluded that marijuana smoking in very young individuals produces changes that might evolve into COPD. Okay, now there was another study that was just published last year, again from New Zealand. And here we see the numbers, smaller numbers than we studied of marijuana smokers. This was also a convenient sample. They failed to find any relationship between marijuana smoking and FEV1 or the ratio, which are the primary measures for diagnosing COPD. They found it only in relation to tobacco. Even the very earliest evidence of the possible risk for developing COPD, and the flow rates at lower lung volumes were found not to be different in the marijuana smokers compared to the non-smokers, nor was there a difference in the diffusing capacity. So these findings are consistent with ours that fail to find any evidence, at least cross-sectionally, of abnormalities in lung function that would indicate the presence of COPD. Now, these are relatively young individuals, and COPD does not begin until later in life. So, as we'll see later, it's important to look at examine these individuals over time, and we've done that, and I'll present those data in a second. But let's look at emphysema. The way emphysema is diagnosed today is using a CT scan. Here we see the holes in the lung this is a whole section of the lung fixed in formalin. And the CT scan is very, very sensitive. And here we see the holes. You could see it even not being a physician or a radiologist. These are the holes. And so you could actually, it's the best way of diagnosing the disease. You can even quantitate the amount of emphysema using this technique. The computer, CT stands for computed tomography, so there's a computer that can process the data and can generate, in this case, a frequency distribution curve of the optical density of the little pixels. Now, when an X-ray beam hits the lung, passes through the lung, its energy is attenuated when it passes through tissue, producing a whiteness or grayness on the X-ray film. If it passes through air, you get blackness. And the blackness means air, and it's associated with an optical density called Hounsfield units of minus 1,000. Water density is 0, bone density is plus 1,000. So here, emphysema is felt to occur if these units are less than about minus 950 or so. So these investigators, the same investigators who performed pulmonary function tests in this convenient sample also did CT scans. And they did find a slightly higher proportion of low-density areas consistent with possible emphysema in relation to marijuana compared to non-smoking. But when they had physicians interpret the CT scans, the physicians found macroscopic emphysema only in the tobacco smoking groups, not in the marijuana smokers. Now, also, you may have heard that there have been some cases reported of bullae. Bullae are essentially like localized emphysema with destruction of just a small portion of the lung, usually at the apices, the tops of the lungs. And there are small case series of patients young patients who have smoked marijuana and have these bullae. And in this particular paper that was reported, there were 4 of these cases. They smoked varying amounts of marijuana and mostly small amounts of tobacco, except for one individual. Well, case series are anecdotal and they're not controlled, so it's not clear whether marijuana smoking truly is associated with the predisposition to these bullous changes, which should not be confused, incidentally, with generalized emphysema. So the real test for whether or not patients with smokers of marijuana develop COPD would be to look at their lung function over time. Typically, the COPD patient will have an accelerated loss of lung function as he grows older. Here we see lung function on the y-axis, age on the x-axis, and we see this accelerated rate of decline. So we measured lung function serially over 8 years in our cohort, and we found that the marijuana smokers had the same rate of change in lung function as the non-smokers, even if they smoked tobacco as well, whereas the tobacco-only smokers had an accelerated rate, as has been reported in the literature. Also, I'm showing the data, but the more tobacco smoked, the greater the rate of decline. In contrast, no matter how much marijuana was smoked, the rate of decline was similar to normal. So I would conclude, I think in the interest of time, that the findings reported so far from different groups of investigators, if you put them all together, it's my belief that they do not support the concept that regular smoking of marijuana leads to COPD.